Afternoon, this is Dr. John Bennett, televising from Miami. Today we have another conference in the series for the ACNS, the Asian Congress of Neurosurgeons. The main topic is emerging topics in neurotrauma. And today we have the pleasure of having Anne Mazzeo. She's an intensivist from Italy. She's going to be talking about advanced neuromonitoring for traumatic brain injury. And we really appreciate Anne making a special effort to connect with us from Venice. So welcome, Anne. Why don't you just tell us a little bit about your background, where you trained, where you're working at now, before you go into your presentation.
Thank you very much. Good evening to everybody. Buonasera from Italy. I am an anesthesiologist and intensivist. I work at the University of Turin in Italy. Actually, I became interested in this neuroanesthesia, neurocritical care area during my activity for neurocritical ill patients. And then I had a great opportunity to attend a clinical fellowship at the University of Richmond under the mentorship of Dr. Ross Bullock. And so I had the opportunity to use several different neuromonitoring techniques during that experience. Now I'm back in Italy. I work as a intensivist in ICU, and I still continue to use this monitoring that I believe they are really very important for a clinician who is dedicated to neurocritical illness. So we can start maybe.
Okay, very good. I'm interested to hear about neuromonitoring. Okay, here we go.
Okay, so we'll dedicate this next half an hour, 40 minutes, to advanced neuromonitoring in TBI. Next slide, please. And we know that among the several different treatment that we can offer to a patient during the acute phase after an acute brain injury, we can offer the opportunity of an advanced neuromonitoring that gave the clinician the possibility to have a early warning that of a deterioration in the clinical setting. So, why do we use advanced neuromonitoring after an acute brain injury? Because sure we will have the possibility to have an early warning of deterioration in the cerebral activity, and we will be able to detect in time that something is going wrong for that patient before irreversible brain damage can occur. And then we have also to say that different neuromonitoring techniques during the years gave us the possibility to better study the pathophysiology of traumatic brain injury. And they gave a lot of opportunity to better understand the evolution of pathomechanism of acute brain injury over time. Please. Next slide, please. So, for people who study traumatic brain injury, we have to remind us that cerebral ischemia is recognized as one of the most important pathomechanisms responsible for secondary brain injury. We know that from different very old studies of the Graham group, neuropathologic studies, that ischemic brain damage has been identified in almost 90% of patients who died because of an acute brain injury. So this is very important because we know that secondary brain injury may worsen outcome after acute brain injury. And at the moment, we also know that detection and prevention and also correction, of course, of secondary brain injury will allow for a better outcome in this patient. And next slide, please. Next slide, please.
Okay.
We know that traumatic brain injury is not a stable condition, but it's dynamic process which evolves over time. And furthermore, when we deal with acute brain injury, we know that we are dealing with an heterogeneous population. And so, as you can see in this cartoon, the pathophysiology of traumatic brain injury is very complex, and we know that part of the problem is related to excitotoxicity. Part of the problem is related to reduced cerebral blood flow, and a big problem is also related to the mitochondrial dysfunction after acute brain injury. So different mechanisms are responsible for the pathomechanism of traumatic brain injury. And we also should know that this process is dynamic. It can change over time. And this is the reason why we can be helped by using advanced neuromonitoring. Next, please. And as I already said, when we face acute brain injury, we face an heterogeneous population. And so we have to be able to match the treatment for that patient and that time. And we have also to be conscious that the heterogeneity is not only between patients, but also within the same patient over time. Next, please. This is an interesting survey of 30 different neuro ICU in the United Kingdom. And as you can see, we have several different neuromonitoring opportunity. And as you can see, we are using them in a different percentage all over the world. And recently, some recommendations from different society are coming out to guide the use of neuromonitoring for acute brain injury patients. Next, please. So, how can we ensure that the brain of our patient is viable after an acute brain injury? Of course, while in the ICU, an important part is hemodynamic management and monitoring. And hemodynamic monitoring will allow us, together with ICP monitoring, to continuously monitor cerebral perfusion pressure. Cerebral perfusion pressure is something that is really important in the care of patient after an acute brain injury. And on the other side, we have also to remember that other systemic complications may occur during the care of this patient population. So other kind of monitoring will help us in the care of TBI. But to go to the central topic of this discussion, we are now offered the opportunity in the neurocritical care to have several different neuromonitoring techniques which give us the possibility to study several different and interrelated aspects of brain physiology, brain oxygenation, cerebral metabolism, and so on. And so during the next minutes, I will try to give some aspects and some characteristics of this monitoring in the clinical practice. Next one, please. So let's start with cerebral macrodialysis. Cerebral macrodialysis is a neuromonitoring technique. It's an invasive, minimally invasive, local neuromonitoring techniques. As you can see in the picture, we have a very thin probe that is inserted either during craniotomy or via bedside Burr hole. And this local monitoring is a monitoring of brain metabolism, which allow us to have a continuous monitoring of the changes that are going on in the brain parenchyma after an acute brain injury. So we insert this little probe into the brain parenchyma. We connected the probe with a macrodialysis perfusion pump, which is a precision pump that can allow to have a rate of 0.3 to 2 macroliters per minute, and we will then be able to collect fluid into vials, and the fluid that we will collect is a reflection of the brain interstitial fluid. And so what can we measure? We can measure anything that can cross the membrane. That could be energy-related metabolites as glucose, lactate, and pyruvate. We can measure marker of tissue damage. We can measure also cytokines. We know that inflammation is a very important pathomechanism after acute brain injury. So with the larger core membrane of 100 kilodalton, we are also able to measure cytokines. And then we can measure also neurotransmitters, such as glutamate, or any drug that we can use during the treatment of these patients. So, for example, cyclosporine has been used during a trial of cyclosporine for neuroprotection. Next slide, please. So, which is the principle of cerebral macrodialysis? So we put this probe at the end of the probe. There is a very small membrane, and this membrane acts as a blood capillary. So any substance that is thin enough to cross the membrane, we can detect it. And so we can, any molecule which is at high concentration in the brain interstitial fluid can vibrate across the membrane. And we collect the vials, and we can then measure what is in that vial. Next, please. Next, please. So how you can see here, these are two examples of macrodialysis analyzers. On the left, you can see the CMA 600, and on the right, the newer CMA Istus. And we can have real time and bedside the possibility to study energy metabolism after acute brain injury. Next, please. Here is an example of a patient during my fellowship at MSTV in Richmond. As you can see, at the tip of the probe there is a golden part that you can then localize into the CT scan. Next, please. Why you should be able to localize this probe? Because it's very important, the location of the probe, because macrodialysis, as I said, is local monitoring, and of course what we can obtain depends on the place where we put the membrane. And for example, in this study, you can see how different can be the detection of the different molecules, depending on if the probe is in the penumbra zone or in the ipsilateral normal tissue or in the contralateral normal tissue. So it's important that we decide the place where to put the probe. Next, please. And another important factor to be considered is also the recovery of the membrane and of the analytes. The recovery, which is the percentage of the molecules in the dialysis as a percentage of that molecule in the brain interstitial fluid. And there are some factors which will affect the probe recovery. That is, for example, the perfusion flow rate. So the slower the perfusion flow rate, the larger will be the recovery. And all the other factors that you can see here in this slide, for example, the blood flow rate, the molecular weight cutoff of the membrane, the dialysis membrane, and so on. Next, please. So, which is the clinical application of macrodialysis in human studies? Macrodialysis can help for the study of pathomechanism of brain injury, not only in TBI, but also in subarachnoid hemorrhage or after stroke or in some kind of epilepsy. Macrodialysis helps clinician to study cerebral energy metabolism and also to detect the effect on secretory amino acid release. But it has also especially an important role in trial design. In fact, macrodialysis has been used as a surrogate endpoint, for example, to evaluate putative therapies. And it has also been studied during clinical and experimental trials to measure the real concentration of a drug which can be administered and can be studied with the purpose of neuroprotection. Next, please. Here is an example of how important is the derangement in brain energy metabolism after acute brain injury. So on the left, we see what will happen in the normal brain. We know that glucose is metabolized into pyruvate, and then pyruvate will enter the citric acid cycle to produce then ATP. But in the event of an acute brain injury and in the event of ischemia, of course, we will have a shift from aerobic to anaerobic metabolism, and so pyruvate will not be able to enter the citric acid cycle and will be reduced to lactate. And the extracellular reflection of this intracellular event will be a decrease of glucose, an increase of lactate, a decrease of pyruvate, and an increase of lactate pyruvate ratio. So this will be able to measure in the macrodialysis, with macrodialysis monitoring. So macrodialysis monitoring will give us the opportunity to better study the arrangement, the dysfunction of brain energy metabolism after an acute brain injury. And we can study how this brain energy dysfunction will be modified over time, and if there is any effect on some treatment that we are using for the treatment of that patient. Next, please. So, as I said, an increase in lactate pyruvate ratio is recognized as the most important marker of tissue ischemia, and normal value are usually considered LP ratio less than 20, and an increase in LP ratio more than 25 indicates shifting of energy metabolism from aerobic to anaerobic glycolysis. And for the clinician, an increase in LP ratio has to be an early warning that an energy crisis is happening in the brain at that moment. We also have to remember that an increased LP ratio has been correlated to regional ischemia in PET studies, and an increased LP ratio has been associated with poor outcomes in TBI and also in SAH patients. And an LP ratio over 40 has been recognized to be associated with severe hypoxic ischemia and with permanent global brain damage. Next one, please. And another important thing to be recognized is that an increase in lactate and an increase in LP ratio may not only be due to reduced availability of substrates as after during the ischemia, but an increase in lactate may be also associated to a mitochondrial dysfunction. And this is very important to be recognized, and this has been very well demonstrated by this study by Paul Vespa, in which he was able to demonstrate that metabolic crisis can also happen without brain ischemia. And in this study, a 25% of incidence of metabolic crisis with LP ratio over 40 was demonstrated, but they also demonstrated only a 2.4% of incidence of ischemia demonstrated by a glucose less than 200 macromolars per liter. So the increase in lactate and the increase in lactate pyruvate ratio may also be due to the fact that the mitochondrial dysfunction will impede the use of oxygen by the neurons. Next one, please. And with macrodialysis, we can also measure the glutamate level. We know that glutamate is the major excitatory amino acid in the brain, and we know that excitotoxicity is recognized as a main pathomechanism of injury after acute brain injury. So we can also look at the trend of glutamate after injury with macrodialysis monitoring. Next one. And we can also measure the visceral level. We know that during ischemia, the energy failure will be responsible for an inactivation of calcium channels transporting system. We will have an overload of calcium inside the cells. And this will be responsible for an activation of phospholipase, and this will be responsible for degradation of the membrane, and so we will have an increase of glycerol that we can detect during macrodialysis monitoring. Next, please. And this is an interesting study that demonstrates that macrodialysis changes may happen even before ICP and CPP changes. So this will allow us to have some time in which we can do something that can help the brain of our patient before irreversible damage may occur. Next, please. Next, please.
Okay. Okay. Oh, oh boy.
Next slide, please. Okay, yes, thank you. So as you can see, this is an example, is a graph in which you can see how the glucose of the patient that you can see in blue is very, very low after acute brain injury. And you can see high levels of lactate. And you can see also the yellow is the glutamate. You can see very high level of glutamate after an acute brain injury. And you can see how these parameters, metabolic parameters, can change over time after injury. And this is allowed by neuromonitoring by macrodialysis. Next, please. Literature gives some tentative normal values that we can use in the clinical practice to see how the different neurometabolic parameters are changing over time. Next, please. And as I said before, we can use also macrodialysis during clinical trials and to measure drug concentration in the dialysate. This can give us a feedback method to determine the concentration of that drug into the brain interstitial fluid. And as an example, as you can see in the next slide, this is a study that we performed at NCD, and this study aimed to look at the effect that the cyclosporine administered to a patient after an acute brain injury, the effect of cyclosporine on brain metabolism. And this was part of a clinical trial, and in this case, macrodialysis data helped us to evaluate the effect of that drug on brain energy metabolism. Next, please. And the recent consensus statement from the International Consensus Conference of Multimodality Monitoring in Neurocritical Care has been published in the Intensive Care Medicine. And this consensus recommend the use of monitoring cerebral macrodialysis in patients which are at risk of cerebral ischemia, hypoxia, and energy failure. And it's very important, and it is recognized also by the consensus that we should be able to locate the probe in the place where it can be more helpful for the information that can give to the clinician, can be given to the clinician. Next one, please. So from macrodialysis, let's move to electrocorticographic monitoring of spreading depression. This is another very interesting new technique that is used to study a very important pathomechanism of acute brain injury, which is spreading depolarization. Spreading depolarization is recognized as an electrochemical wave which propagates through the neural tissue after a pathologic stimulus and trigger. That may happen and may occur after acute brain injury. This trigger could be a local failure of brain energy metabolism, or an increase in calcium, or an increase in glutamate. And what is most important is that the occurrence of these spreading depolarizations may worsen outcome. And in the picture, in the upper part of the picture, you can see the placement of an electrocardiographic monitoring at the end of neurosurgical procedure for TBI. And along with this, you can see in the white arrow the microdialysis monitoring placed at the end of the surgery. So the combination of these two monitoring can give us a better opportunity to study the patient after acute brain injury. Next one, please. And this is a study that we performed at MCV in Richmond, where we demonstrated that spreading depolarization was more frequent during secondary insults, such as low blood pressure, hypotension, and fever, high temperature. So this is also a very good demonstration that secondary insults may worsen pathomechanism of brain injury and may be responsible for a worsen of outcome. Next, please. And in the similar study, we also demonstrated that glutamate is increased and LP ratio is increased with the increasing number of spreading depolarization. Next, please. So let's say something about brain oxygenation. We know that brain oxygenation is a very important parameter to be monitored after an acute brain injury. We have different systems that allow the study of cerebral oxygenation. The first two that you can see in this slide are brain tissue oxygen tension and jugular bulb oximetry. These are invasive monitoring. Then we have a third one that is a non-invasive one. It's the use of near-infrared spectroscopy, which allows us to have a transcranial cerebral oximetry that is non-invasive, but is, of course, has several limitations. Next slide, please. Brain tissue oxygen monitoring allows us to measure the level of oxygenation at tissue level in the brain. So we have to put a small probe, so it's an invasive technique, minimally invasive technique. It's a local monitoring because we only study the small area which is around the probe, but the information that we gain is a very important one because we are able to measure the tissue oxygenation after an acute brain injury, and we can see how the oxygenation may evolve over time, and we can also study the effect of different therapies and corrective measure in the case of a reduction of brain tissue oxygenation. Right now, we have two systems available. The first is the Lycox, the other is the Neurotrend. They gave us the possibility to measure continuously the brain tissue oxygenation after an acute brain injury. Next, please. And as you can see here, this is a demonstration how with the increasing of ICP, we will have a reduction of brain tissue oxygenation. We will have an increase of CO2, in the cerebral tissue, and we will have also decrease of the pH of that tissue with the increasing ICP. Next, please. And a very important clinical message is that we have to recognize that we can have some important information when brain oxygenation is becoming insufficient for that patient. So compromised brain tissue oxygenation is recognized to be less than 20. And what is more important, it's not only to look at the absolute value, but also at the trend of that value. And it's important also the duration of the compromised brain oxygenation and it is recognized to be related with worse neurological outcome after acute brain injury. Next, please. It has been demonstrated in this study comparing patients studied with ICP and CPP monitoring and patients studied with ICP, CPP plus brain oxygenation. It has been demonstrated that the patient who has been studied with brain oxygenation, they had a lower mortality rate and favorable and more favorable short-term neurological outcome. And this, of course, was a very important result. And then, as you can see in the next slide, please. Of course, if we have a monitor, we need to use the information that that monitor is giving us. So this study demonstrated that there are some therapies, treatments that we can use to correct a low brain tissue oxygenation. And of course, the different treatment depends on the different causes that are underlying that brain tissue oxygenation reduction. For example, it has been demonstrated that if the brain tissue oxygenation was less than 25 milliliter of mercury and ICP was more than 20, then we had to use a measure to reduce ICP. Or if the reason for a reduction in brain tissue oxygenation was a pulmonary problem, then we had to solve that pulmonary dysfunction. For example, by an increase in FiO2 or an increase in TIP, or if the patient is not adequately sedated, then we have to increase analgesia and sedation for that patient. So we have to treat that patient accordingly to the mechanism of the injury at that moment. Next, please. Beside brain tissue oxygenation, we also have another oxygen monitoring, which is jugular venous oxygen saturation. This is global monitoring, which gives us an estimate of the balance of global oxygen delivery and cerebral metabolism. The normal value is around 60, 75. We need to put a small catheter into the jugular vein, and it will be then moved cephalad, and it has to arrive at the level of C1, C2 to give us the better monitoring. And studying jugular venous oxygen saturation, we will be able, on the one side, to study oxygen delivery, and on the other, oxygen consumption. As you can see in this slide, in the case of reduction of jugular venous oxygen saturation, we have to think either to a decreased oxygen delivery or to an increased oxygen consumption. So the cause of a reduction of the venous oxygen saturation could be, for example, increased ICP or an excessive hypocapnia, but could also be pain or hyperthermia or an increased metabolism. If we have a high value of oxygen saturation, we may think about increased oxygen delivery, for example, in the case of hypercapnia, or if we have an increased cerebral perfusion pressure. But on the other side, the increased value could be related to a decreased oxygen consumption, for example, during hypothermia or during deep sedation. Next, please. It has been demonstrated that this monitoring can be related to neurological outcome, and it has been demonstrated a strong association between jugular desaturation and outcome, and also the duration of the time that SjO2 was below 50 was significantly related to a worse outcome. Next, please. Just a few words to say that we also have some non-invasive monitoring to study transcranial cerebral oximetry. This non-invasive technique is based on the principle of transmission and absorption of near-infrared light. And the importance of this monitoring is that it allows us not only to study a trend over time, but to see at the difference on both sides. We put two electrodes in the frontal region, and we can have a measurement, continuous measurement of regional cerebral oxygenation at frontal level in non-invasive. Next one. And the recent consensus conference recommend the monitoring of brain tissue oxygenation in patients with the risk, which are at risk of cerebral ischemia or hypoxia. So monitoring tissue oxygenation, cerebral tissue oxygenation, is recognized as an important monitoring which can affect neurological outcome during the acute care of these patients. Next, please.
Okay.
And we are just going very quickly to the end. We need to remember that another monitoring parameter that is important in the care of this patient is cerebral blood flow monitoring. As you can see in the next slide, we can have the possibility sorry, next slide, please. We have the possibility to insert a thin probe that is a thermal diffusion probe that gives us a quantification of tissue perfusion in that area. So this could be another parameter that we can measure in the care, during the acute care of a TBI patient. Of course, the different parameters will give us different aspects of the pathophysiology of that patient, and what is important is to select which patient may benefit of which monitoring. Next, please. This is another way we can measure cerebral blood flow with Xeno CT Scan. Next, please. Just a few words. We have also the possibility to use transcranial Doppler during the care of a TBI patient. It allows us at bedside and with low cost to measure, for example, cerebral autoregulation after an acute brain injury. Next, please.
Okay, hold on, I'm a little lost here. Give me a second.
Yes.
Okay. Okay. Is that okay? Okay.
Yeah, okay. And as you can see here, when we care for the traumatic brain injury patient, especially not in the very early phase, but after the first week, we can also rely on some information given from somatosensory evocad potential, so we can have some help also from neurophysiological monitoring, which, for example, can help us in the patient who is under sedation, or in the patient which have some metabolic derangement that can confuse the neurological evaluation. And of course, we all know that a lot of information can be obtained also with the use of continuous EEG monitoring in selected population. For example, for patient in which we suspect subclinical seizures. Next, please. Here is the recommendation for electrophysiological monitoring from the same consensus. They recommend EEG in all patients with acute brain injury and unexplained and persistent altered consciousness, or, for example, in patients with continuous status epilepticus, which do not return to the baseline activity within 60 minutes of seizure medication. Next one, please. At the end, I would like to remind to myself that, of course, each of these monitoring, as I tried to quickly explain, can give us information of a particular aspect of brain physiology, for example, cerebral blood flow, or brain metabolism, or brain oxygenation. If we can have the possibility to put together all this information, of course, the overall picture of the patient will be much more interesting and more useful for the clinician. And as you can see in the next picture, we can have the possibility to use some platforms which will integrate all these different systems and can give us a better picture that will allow a better monitoring of the patient. Next, please. And as you can see here, the same guidelines recommendation suggest the use of a display that can help the clinician not to be confused with all the information, but to use an integrated system that can integrate different data from the different monitoring systems. And at the very end, the next slide that will be my last one, I would like to remind myself which is the most important aim target for the use of neuromonitoring tools in the patient with acute brain injury. So why can we use and should we use this monitoring? We can use and we should use some monitoring that we saw during this presentation, because this monitoring can give us an early warning of a secondary cerebral deterioration, giving us the possibility to use targeted therapy when we are still in time to do something that can avoid irreversible brain damage. So the reasoning for using neuromonitoring, first of all, to detect secondary insult and clarify the mechanism of injury. Then, as we saw, neuromonitoring can give us a lot of important information to study and to understand cerebral energy metabolism, which is in crisis after acute brain injuries. And then, as we saw during some clinical intervention, we can have some very important informations on the effect of some drugs or some intervention on brain physiology. And so this monitoring tool, on the one side, they can help the clinician in the daily activity, but they can also help the researcher during the different studies, experimental and also clinical study, to better study the pathomechanism of injury and to better study neuroprotective therapies. Thank you so much for this invitation, and I hope I was able to give just some basic information of a very important topic in acute brain injury. Thank you.
Great, Anne. I really appreciate your effort to connect with us, to give the neurosurgical community, the Asian Congress of Neurosurgery Society, and the followers one aspect of care of traumatic brain injury. And like you said at the end, I think with the with the effective use of computers and big data to make algorithms, to make it simple for physicians like me and for neurosurgeons that really probably don't spend too much time studying neuromonitoring, a method of better dealing with traumatic brain injury. So I really appreciate it. This is recorded, and this hopefully will be part of your future in talking to neurosurgeons around the world, because we want to basically use this platform to reach many people in the ways of communication, the best ways of communication we can. Just like you analyze machines to analyze things, we want to use machines to educate, basically, in topics that you're talking about, to give physicians that don't have a chance to go to a conference, that are too busy, and that need to learn things like what you put a heck of a lot of work into that presentation. You've done a lot of research, right?
I have done a lot of research, especially while I was working at MCV with Dr. Ross Bullock, and I am continuing also doing this kind of research right now at the University of Turin. That is my actual position in Italy.
Oh, yes. Okay. So you were practicing intensivist, or do you basically do research?
I do both things because I work in the ICU, and I am also part of the university as with the position of assistant professor of anesthesia and intensive care. So I need to dedicate part of my work to research and part to clinical activity. And as you know, the best way is to integrate both things
Yes, yes, it is.
and the
And,
results.
and I'd like to ask one favor of you, Ann.
Yes?
I want you to tell the first two Americans you run into that it's good luck to swim in the canals.
No, it is not possible to swim in the canals, especially if you have to give a lecture.
Okay, Ann. I'll email you the copy of the address of this talk, but thank you very much.
Thank you very much. Thank you.
Bye-bye.